Mrs. M, 28 years old, lady, G4P2L2, A1 at 30 plus 6 weeks gestation with antenatal risk factor of severe anemia, with one history of abortion, the third pregnancy, and now came with fourth pregnancy. Came with complaints of fatigue for 4 months, fever and skin lesion over the face and head for the past 3 months. No other significant history. She has had a severe anemia in the second trimester, for which she required 10 packed cell transfusions. So this is the image of the skin lesion. Any differentials you would like to? And anyone wants to describe the skin lesion as well? So I'll come back to this. So on examination, vitals were stable. Pulse rate was 92, blood pressure 120 by 60 febrile. General examination, there were bilateral submandibular and cervical and left axillary lymph nodes were palpable. Systemic examination, cardiovascular system, a flow murmur, systolic murmur was heard in the aortic area. Apart from that, there was no significant findings. So describing the skin lesion, it's a violaceous nodular lesions on the left side of the face with forehead, involving the forehead, the eyebrows, and the cheek, with a central puckering and a surrounding erythema. So this lesion is specifically non-tender, with soft to firm in consistency. And with the given history of summarizing the history with fever, fatigue, and papillonodular violaceous skin lesions with history of multiple transfusions and clinical examination of generalized lymphadenopathy. Now, any differentials you would like to consider? So, so first differential would be a cutaneous manifestations of HIV. So there are different manifestations of molluscum ecthyma, bacillary angiomatosis, prurigo nodularis. Since it's in the face, so BCC is can be one of the differentials. Non-melanoma skin cancer, SCC. Second, amyloidosis differential. However, the skin lesions in amyloidosis are pruritic and tender. However, this is non-tender. Third, other differentials we can consider sweet syndrome, leukemia cutis, cutaneous mycosis. Now, coming to investigations, her HP was 4.8, normochromic, normocytic. Total counts were elevated, 52,150. Platelets, reticulocyte count is normal. Renal functions and metabolic parameters were normal. Liver functions, only alk-phos was elevated. Coagulation parameters were normal. LDH was mildly elevated. BBVS was negative. Fibrinogen was 600. So we have asked for the peripheral smear, and it showed a myeloblast, picture of a myeloblast with a fine chromatin 2 to 3 nucleoli with having vacuolations, with few blasts having OR rods. So it was suggestive of acute myeloid leukemia. So summarizing everything together, Mrs. M, G4P2L2A1, 30 plus 6 weeks, came with fever, fatigue, papillonodular violaceous skin lesions, which are non-pruritic, non-tender on the face and head, with generalized lymphadenopathy. So it's a AML in pregnancy with probable leukemia cutis, since the peripheral smear had showed a blasts, myeloid blasts. So coming to the leukemia cutis, I'll be presenting leukemia cutis today. So it is actually infiltration of neoplastic leukocytes in the epidermis, dermis, and subcutis, which clinically becomes identifiable in the skin. And whenever there is a leukemia cutis in an AML, there should always it always has a dissemination to the CNS. We should always look for a CNS features. However, this patient did have any focal deficits, and it's almost 17% CNS localization is there. And it's AML with leukemia cutis is rare, with the incidence of just 2.9 and 3.7%, and 7% of cases are aleukemic leukemia cutis. And this leukemia cutis can follow, precede, or occur concomitantly with the diagnosis of systemic leukemia. And presentation can vary from just a erythematous to a violaceous papular nodules being the most frequent one. And typically it's a firm or rubbery in consistency, and it can become purpuric when the patient is thrombocytopenic. And mostly it is involved in M4 and M5 AML lesions, and has been reported to high in these lesions, 30% rate. So these leukemia cutis is also seen in other lymphomas, like the most others are CLL, adult T cell, and T cell prolymphocytic. However, the one which is marked with +3 are having multiple nodular lesions of leukemia cutis. There are also reports available where single nodular lesions are there in cases of Hodgkin's lymphoma and lymphoblastic lymphoma, where there is only a single nodular skin lesion will be there. This is an article from the systemic review from Blood Journal, in which they found that the age group which was most common was more than 60 years, which is more common in AML. And mostly it was these lesions were multiple in origin, and mostly they were involved in trunk, followed by head and neck. And the most common appearance were the nodules and papules. The pathogenesis is unknown. However, the recognized one is the homing of the malignant cells. It's the migration and the fixation of these blast cells in the endothelium of the dermis because of the communication with the LFA and the ICAM antigen and CLA and E-selectin. However, still the pathogenesis is not confirmed. So the diagnosis is purely based on a biopsy and a immunohistochemical staining, in which biopsy will see a subepidermal grain zone with a multiple lymphocytic infiltration, and it is also positive for myeloperoxidase staining. We also do immunohistochemical marker, which is positive for CD43, 68, and lysozyme. However, other markers are also positive, like MPO 33 and 117, which is positive for AML as well. However, in cases where the CD117 and MPO immunostaining are negative, but it's showing lymphocytic infiltration, probably a monoblastic skin infiltrates, which is probably a M5, M6. So there are other mimickers as well of these leukemia cutis, which I would like to highlight. So first one is you will have similar picture, which is early leukemia cutis usually comes with a erythematous papular lesions before it becomes a nodular encrusting with a blast cell showing a plasma cell like feature on the peripheral smear. So these things are blastic plasmacytodendritic cells. However, we can differentiate it by using CD marker CD4 and CD56. There are other mimickers as well. Metastatic malignant melanoma, Ewing sarcoma, medulloblastoma, histiocytic sarcoma, which is also positive for CD68 and lysozyme, which was more sensitive for the AML, which however, it will be negative for CD33 and 13. They also look like similar to this manifestation. Other lesions are CLL, which is also similar. However, the characteristic is the CD marker as well as the localization of the lymphocytes, which will be perivascular and nodular pattern, and it will be in a lichenoid fashion, which is also positive for CD25 and 43. So the management is just to treat the underlying leukemia. However, reports have been found that there are no good studies for the management of it, but it has shown that it is less responsive to chemotherapy. For these local skin lesions, the treatment is radiotherapy with photon and electron beams. So our patient, we had done a bone marrow, reports are awaited, skin biopsy reports are awaited. So the family has been, decision has been counseled regarding the delivery, and patient has been started on hydroxyurea, febuxostat, daily monitoring of counts, uric acid, and other electrolytes, phosphates, target hemoglobin of greater than 7, and patient is on IV hydration. Steroids is been planned, and patient is planned for delivery at 33 to 34 weeks. So if the patient comes in first trimester with AML presentation, it's usually patient termination of pregnancy is advised. However, when the patient comes in second or third trimester, then the patient can be started on the cytarabine and daunorubicin, but the family should be counseled regarding fetal malformations and other things. However, induction phase followed by consolidation phase, as normally we can go as in a non-pregnant female. So this is a study in which AML in pregnancy, in which 87 women with AML were studied.
Osborn, I'm so sorry. I'll just stop you now only because I think they have a session here at 9 and we need to complete it. Is there anything else that you want to tell us?
This is just complications of the AML in pregnancy, hydrocephalus, VSD, and cytopenias in ICH, and the one which I already said, first trimester usually goes into abortion.
Okay. Sure. So anyway, I think this is a very interesting case. And also, you made the diagnosis based on?
So clinically and the peripheral smear, but skin biopsy is the diagnosis.
And the question I have is that appearance that you just described, that punched out
yes,
lesion with raised margins and lymphadenopathy, quite pathognomic of leukemia cutis?
Yes, sir. Clinically it is, but we need to do biopsy. There are other mimickers which I have mentioned, like SCC, BCC, which can also has a similar presentation. For that, we need CD markers and biopsy.
Okay. No, because BCC again, it's more of a nodular lesion. It's not really a punched out lesion. So,
but since the peripheral smear showed the.
Okay, so you went based on the peripheral smear along with. So for your patient, has the biopsy report come yet?
No, sir.
The biopsy report is still pending, and you plan to give what?
So hydroxyurea, febuxostat, and hydration.
That is the immediate management. Subsequently,
since patient is in third trimester, we can actually start on cytarabine and daunorubicin, but patients still being counseled regarding the same, but with associated added risk of fetal malformations.
Thank you. Any questions? Okay, let's move on. The next case will be presented by Medicine 4, dark bronchus by Dr. Brightus. Brightus, you have only 8 minutes. So we need to wrap up.